Welcome to our lecture video on drug-related problems. As a future pharmacist, we can secure our patients' health outcomes by knowing our role on management of drug-related problems. This time, we will talk about specific drug-related problem, and that is our drug adverse reaction or our ADRs. So we have adverse drug event and adverse drug reaction. An adverse drug event is an injury that results from medical intervention related to a drug, and that includes ADR. So an ADE, it includes preventable reactions, including those caused by human error, but it's not necessarily caused by error. So an example again for adverse drug event is an adverse drug reaction. This ADR is a response of our body to a drug that is obviously noxious and unintended, and that occurs at doses normally used in humans for the prophylaxis, diagnosis, or therapy of disease, or for the modifications of physiologic function. So these ADRs are results of the intrinsic properties of our drugs and cannot be prevented, but it can be managed. So the risk factors for ADRs includes age. Commonly, pediatrics and geriatrics are predisposed or experience ADRs most often. With regards to gender, female is mostly or notably experiencing ADRs compared to male. We have also risk factors for comorbidities. The disease states or the physiologic state of our patient, which has been altered by the comorbidities, can make a patient susceptible to experience an ADR. Another risk factor a patient may possess that makes him susceptible for ADR is polypharmacy. So, if a patient is having many drugs or taking many medications and taking it for a longer time, with a combination of a narrow therapeutic index drug and a maintenance drug, that makes a patient more susceptible to experience adverse drug reaction. Another risk factor includes ethnicity and genetics. So there are genetic polymorphism that can cause idiosyncratic reaction or reactions unexplainable by science. Moving forward, our ADRs or adverse drug reaction can be classified into severity. We have mild, moderate, severe, and lethal. So if our ADR is considered mild, we don't need an antidote or treatment. But if there is a need for hospitalization, it can be done, but it will not be that prolonged. An example for that, if we take antihistamines. So if we double dose an antihistamine, a first generation sedating antihistamine, it can cause pronounced drowsiness. Another is if we take opioids in longer duration that can cause a pronounced constipation. But those different manifestations are not serious and does not really need an antidote. You just have to let the drug be excreted in the body and allow the drug to subside its pharmacologic action. The next severity is moderate. Moderate, there should be a change in treatment and hospitalization may be prolonged or requires special treatment. An example for this if a patient uses oral contraceptive pills that is high risk for developing venous thrombosis. Another is a GI problem or hypertension resulting from prolonged use of nonsteroidal anti-inflammatory drugs. Severe ADR or potentially life-threatening ADR that requires discontinuation of treatment includes the use of our ACE inhibitors, which can cause angioedema, and then we have also phenothiazine that can cause abnormal heart rhythm. If our ADR directly or indirectly contributes to patient's death, we consider it as lethal. For example, our anticoagulants, if prolonged use, it can cause hemorrhagic bleeding.